Dr. Bogale Worku will present us the diffusion of kangaroo in Ethiopia. Dr. Bogale Worku is professor of pediatric and child health since 25 years to under postgraduate student at Addis Ababa University. He is also the executive director of the Ethiopian Pediatric Society.
Thank you, Natalie. I would like to thank the organizers of the conference for allowing me to come to Madrid and also present the diffusion of and the status of kangaroo mother care in Ethiopia. Let me start with giving you a little bit of background of where Ethiopia actually is, because some of us may not really exactly know where it is. So it's in the Horn of Africa, where we have 120 million people and 3 million birds annually. Out of these 3 million birds, 10% of them are preterm and premature. So you can calculate that about 300,000 preterm babies are born every year in Ethiopia. Again, another epidemiologic background, which is probably a very good hint for us here, is the contribution of newborn days for the under 5 mortality goes to 52%. And sepsis, asphyxia, and prematurity, all the three adds up to 90% of all neonatal deaths in the country. When you look into the preterm population alone, 88% of mortality comes from RDS infection and breathing problems. So I think this as a background, then one really need to go into what can I do for these babies in my country or in a given country. Another data that also gives us the situation in the country for the last 15 and plus years is the status of neonatal mortality per 1,000 births is more or less remaining the same, starting with 39, going a little bit to 37, 29, and coming back to 33 per 1,000 days. This is probably one of the highest neonatal mortality ratio globally. Having said this, now going into the kangaroo diffusion and status of kangaroo mother care in Ethiopia, by the way, the term diffusion is an appropriate term because it tells you its movement into every corner of the places where it is required to be. So really it's a diffusion. So the genesis of KMC in Ethiopia starts with this journal. I don't know how many of you have seen this journal. This journal has been circulating globally 2 decades ago. I don't see it now anymore. And I have asked my colleague Adriano Cattaneo, who was actually behind this journal, and he told me it's no more published. But all my history, or history of KMC in Ethiopia starts within this journal. This journal, the Terrestre team working in Mozambique, they reported a mortality reduction by using KMC. In my unit, the mortality was so high, so anything that reduced mortality without high tech was very attractive to us in the team. So it really attracted me. And I had to communicate with the authors, Riccardo Davanzo and Ornella Licento. I think you may know these people. So they gave me more idea on what KMC mean and how it works. But we had to really go to a place where it was born. It was just like going to Mecca or Jerusalem for Christians and for Muslim brothers going to Mecca, to go to Bogota is just like that. So at this point, I would like to really thank my colleague, Natalie Charpak, and the late Thita. Please join me. Thank you. Their contribution is really immense, especially in African countries. We were going there for 6 weeks in tours, a nurse and a doctor from almost all of Africa and Southeast Asia, from the South America also. I don't know, from Europe maybe, but I know for certain that these are the continents where we're going to Bogota really to learn exactly how KMC works. So that's really, the credit goes to these two giants. So after really communicating with the Trieste team, they actually organized a multi-center study with my colleague Shashivan when she reported earlier. And we conducted a study. Is KMC really working in developing countries, different culture? Does it cost us anything? Are people accepting it? Those were the questions that we tried to answer. And we conducted that study, and we reported in, I think it must be the first Congress of KMC. And that Congress was almost only this part. It was a very small Congress. I'm very much amazed to see it grow to this level now. But that time, it's very few people. I see Suzanne here. I see Adriano and his wife, Sofia, Natalie, and Sashivan, and maybe some few others also. 25 years ago. So it was a small community. So that has now grown to this level. I'm really very lucky to be just in front of you after 25 years. Probably you can see the change that this is me, I think. Yeah, so I'm lucky. So, this was the first KMC mother, the mother on whom we put the baby for the first time. Every one of us were so excited, and we didn't know whether really the baby is going to fall down, and whether the baby is going to be suffocated, and whether the mother is happy with that. So anyway, this mother was willing, after counseling, to hold the baby in KMC position. And then followed by these ladies who are showing some smiling faces. At least one can, even though we tell them to laugh, but unless you have satisfaction within you, even if somebody tells you to laugh, then you can't really laugh adequately. So, but these ladies were really happy by giving KMC for their babies. So, now, the situation, maybe in other countries also, but, the challenge, when we wanted to make it a little bit increase into or enroll other hospitals, and asking the Federal Ministry of Health to support us, to agree with us to do that, then they told us, what's new about KMC? Our mothers carry babies on their back, so what are you talking about? So, but it's not true. As you can see, babies are carried at the back for when they are able to support their head. Even though I have seen a very recent research output which says carrying the baby at the back is almost equivalent to KMC. I don't know whether you have seen that. But that's not really true, because the babies need to support their head to be at the back of their mother. But anyways, the challenge from the officials of the Ethiopian Ministry of Health was that it's not new, it's the same, it's only a change of position. And we had to really work hard to convince them that it's not the same. So we had to do really a lot of works, and that work actually involved partners. There are many partners operating in Ethiopia, the money from UN agencies to other local NGOs. But they were, luckily enough, they were all happy about the outcome that has been published and advocated by UNICEF globally, World Bank. And so they said, we'll support. So they really start supporting us. So we started to do KMC in a small number of hospitals. Later on, we really integrated the KMC. We don't have Kangaroo Mother Care Foundation like in Philippines or in India, because it's not acceptable there in Ethiopia. They say you have to integrate it. We can't afford, because they have seen the standalone programs of tuberculosis, malaria, ARI, diarrheal diseases. And later on, thanks to IMCI, they integrated all these clinical conditions, which is really cost effective. And so they said, no, if it is a standalone, we don't support. So we had to integrate this into the Helping Babies Survive. So in Helping Babies Survive, there is KMC. In the NICU nurse training, we have, the newborn nurse, by the way, in Ethiopia is very young in terms of existence. So when we start training nurses, shifting tasks from doctors, pediatrician to nurses, we had to train nurses. So on that training manual, we have included KMC. So KMC is in the training manuals. So if somebody wants to establish a NICU in a given hospital, then KMC is a must. So it's part of that intervention. So we had to go to the television studios to try to do some advocacy works, dissemination of information, because it's totally new to the country. People don't know even what kangaroo is. I remember once in a meeting where people say, why do we use kangaroo mother care itself? And so we had to really do a lot of dissemination works and training materials in local languages, counselings and discussions. So we started with one site, and luckily enough, when we started KMC, my unit or my hospital was the only hospital running the graduate program in pediatrics. So our residents were trained and were placed in 3 other hospitals in the country, where they took the method and started the KMC in their facilities. And that's how we really started replicating itself. So now we have close to 250 sites where we have KMC interventions together with NICU services. Another story is the story of starting KMC early. In 2005, we said, from our previous study, we knew that only we could enroll 30% of the eligible babies. 70% of babies could not be enrolled because they die early. You have seen Neil's presentation in the morning that the duration of days happening in the first 24 hours and the first week of life. So all KMCs that we used to do was after 1 week. So we could only enroll 30%, and 70% are not benefiting from any of the KMC advantage. So we said with my friend, and of course, the initial KMC Congress also suggested, let's see if KMC works early. That was the initial recommendation. I think Adriano can remember, and others also will remember. Let's see if it works early. That's 25 years ago. Then we were bold, not only bold, but we want to save as many newborns as possible. And our primary intention was only to save them. We don't know about the brain development, the benefits of brain development and psychological and the neurobehavioral, the pain, all the research findings that we have heard before yesterday also. We don't know about those. What we know was only to save them because they were dying. So we tried. So we enrolled 62 into early KMC. Early, we mean as soon as they come to us from the delivery room or from home. Most of them were coming from home. And even if they are sick, and even if they needed oxygen administration and IV fluid and antibiotics, we randomly assigned them into the conventional method of care and KMC. Now, at that time, actually, we don't know also the CPAP. The CPAP came to us after this time. So oxygen delivery was, it was a free flow oxygen. So we were giving them oxygen while the babies were on the chest of their mother. So we found very amazing result, which is quoted by many of the speakers actually, but nobody dared to try to prove or disprove it for a long time till the recent, of course, there were here and there, but the WHO, the multi-center study came up with now IKMC. So now we do unpack our safely packed finding of 15 years ago, and now we are courageous now to start and to also boldly tell the government that it's possible to start KMC right from birth onwards. And we are very happy now because the government listened to WHO than us. So it's a really right time to directly go into the implementation. So what's happening now, what has happened actually in the Ministry of Health during these years is a lot of changes in the document production in the ministry, like the child survival strategy document has included KMC as really part of the care of preterm babies. So that has been revised twice, and the latest one is under the process. Again, the World Prematurity Days have also helped us in bringing up the issue to all the regional health bureau officers, where they are also, again, very keen to support in any ways, whatever it costs to establish KMC in their NICUs. More recent one is a Health Sector Development Plan 2, which has included, again, kangaroo mother care, not only including it with a target to reach 75% of all eligible babies should be receiving this method of care in 2025. And that's really a great achievement, because the government, who used to say that carrying a baby at the back and in the front is the same, has now put a target of really reaching 75% of their babies through a lot of advocacy workers. But the issue is, even though all these things is happening, the coverage is not that high. The administrative coverage is like 50% of babies are receiving KMC, but there are some figures which shows lower rates. So I will come back to this. So what can we do to improve then the further diffusion and see what facilitate and what inhibit, or what are the barriers? So we did the study again together with Indian colleagues. This was also mentioned by Suman on Monday. So kangaroo mother care implementation research to develop models for accelerating scale up in India and Ethiopia. This was a study protocol. So in this model, what was recommended is to see really what helps improve the scale-up of KMC at the community level. So what are really there in the community that helps mothers to bring their babies to facility in KMC position. And another is in the facility level, and also later on after discharge back to community. This is post-KMC in the facility into the facility level. So these were some of the things that has been done recently. And from this study, again, we tried to see exactly what are the barriers that has affected from scaling up KMC of this age long, I mean now 25 years. So we did that, and we came up with these barriers that are really found to be key. These are the KMC knowledge, though we thought is known, but we found out that knowledge is still a lot of knowledge gap within the health workers and the community also. So that's one important issue. Attitude and practice, and the community's belief and values for preterm babies. You know, in Ethiopia, preterm baby is a curse. People consider this as a curse. And baby who was born preterm is someone who is really below the human being. So this has to be reversed. Professional acceptance of KMC, motivations to implement KMC practices, and shortage of supplies and infrastructure. These are some of the issues that were identified as barriers. So the recommendation from this study was to use it as a comprehensive, like I said earlier. We have to do it as integration, and the comprehensive approach with systematic intervention and support at maternal, family, and community level. So these are the things that we identified. Just to say a few things on the pictures. These are some of the pictures where mothers come up in front of the audience to give testimonies of KMC that really will be broadcasted through medias. And grown-up babies who were in KMC were also doing testimonies. Yeah, this is a lady on the left, on the right side is a community health worker that is implementing KMC. Actually, we try to see if the KMC can be implemented. Actually, this is universal KMC, meaning that we don't have weight limit or gestational age limit, but for all babies. So we found, and that is published also, that it's possible and feasible to do KMC at the community level. So I think, in summary, our KMC is now the government has accepted this as real standard of care for preterm babies, and they developed with the leadership of the government. They very recently developed implementation guide. Luckily enough, the WHO document, we already knew that WHO is going to produce a guideline for IKMC, so this implementation guide has the benefit of including the WHO's recommendation, and so we have that in place. That means implementation guide developed by government means then the government is going to really be responsible for whatever it is. It's not me or it's not an individual, but it's a system. The system is going to accommodate all the things that are related to KMC. Thank you. This is all I want to tell you. Thank you.